Hi, I'm Kelly Walkovich. I'm one of the assistant professors in the Department of Pediatrics Division of Pediatric Hematology Oncology, and I happen to be the director of the Immuno-Hematology Comprehensive Program, and I want to take a moment to thank everyone for coming out today for our symposium. We are very excited to have you all here. I also wanted to take a moment to recognize that today actually is Rare Disease Day, and this is a worldwide event celebrating the many rare diseases that most of us in the room spend our days, both clinically and research-wise, investigating and taking care of. And while the diseases that we often see are literally 1 in a million or 1 in 5 million, the truth is that many of them are becoming more frequently recognized, and collectively they represent a huge population of patients. So I think today's symposium is a nice reflection of all the effort that's going on here at the University of Michigan and nationally to try to help solve some of the puzzles that are being projected to us by our patients. When we thought about putting this Immuno-Hematology Comprehensive Program together a few years ago with all the interested parties, we had 3 main aims. The first of which was clinical. Our first aim was to establish a multidisciplinary, family-focused clinic for the care of patients with immunohematologic disorders. Like most institutions, ours here at the University of Michigan had these patients sort of scattered amongst different clinics, whether it be allergy, immunology, infectious disease, pediatric hematology, GI sometimes. And the real expertise wasn't being brought together because most of these groups weren't talking to one another or even were aware that there were multiple patients with these rare diseases even on our own campus. Our second aim was research-focused. We were very interested in creating a platform within our program to conduct clinical, translational, and bench research in this subset of disorders, for which we'll discuss what progress we've been making. And then our third aim was really educational. We wanted to utilize this program as a unique educational forum for the training and recognition, diagnosis and evaluation, as well as the treatment of immunohematologic disorders. It's hard enough to take care of these patients when you're trained to quote-unquote expert status. However, the next generation of trainees that comes through are going to have even more to contend with as we recognize new immune deficiencies, new hematologic disorders, and new relationship between disorders that weren't previously known. And so making sure that our trainees who come up through the ranks can recognize these patients when they show up in their primary care clinic, in the emergency room, or even in their subspecialty office will be important. So looking first at our clinical aim, we are very happy to report that we have a strong immunohematology comprehensive clinic. This clinic was established in January 2012 and has 2 main features. It's unique in the fact that it's heavily multidisciplinary and that it has real-time inter-provider patient discussion. And by multidisciplinary, I mean literally in the same room. We have a hematologist, an infectious disease doctor, a bone marrow transplant physician who specializes in the transplant of these disorders, an immunogeneticist. We have our allergy immunology fellows. We also have a pharmacist who's dedicated to our program and a social worker who's dedicated to our patients, sitting in what we call table style all around after we see patients. And this has really led to an incredible amount of diagnostic capabilities and streamlining for the patients. The families love this. They sit in one room, sometimes from 8 until 5, to see all of us, which can be overwhelming, but it's very rewarding by the end of the day. And we have caught a number of patients that I think we otherwise would have missed. In fact, our very first patient ever who came to our clinic was in January of 2012. We had our pre-meeting. It was a 7-year-old boy who had been diagnosed at a young age with complex cardiac abnormalities that had been corrected, but he had some subtle immune deficiency. He was actually referred to me as hematologist for the evaluation of leukopenia, which hematology here mostly sees the neutrophil disorders. We sort of have a soft break where infectious disease will often take the first crack at lymphopenia, which is what this patient has. So we rerouted him to Terry Stillwell, who's here in the front. But Mark Hannibal, our geneticist, was in the room and taught us the equation that cardiac abnormality plus immune deficiency equals genetics consults. So because of that, we queued the patient up to see genetics as well. And just with the flow of the day, it turned out that Mark actually went into the room first. And the kid had a very typical, at least to Mark, facies. And he literally shook the mom's hand and said, you know, it's nice to meet you. I'm Mark Hannibal. Your son has Kabuki syndrome. And the mom just about fell out of her chair because she had been to many physicians in many places for that. And I think that patient would not have been recognized because they had come to me. You know, we would have talked a little bit about the lymphopenia, probably not made any interventions because it hasn't been too significant, and he would have been on his merry way, and the whole diagnosis would have been missed. But thankfully, for our group approach, this worked really well. Most of the main faculty, who I'll talk about in a little bit, are actually pediatric trained, but that doesn't mean that we limit ourselves to pediatric patients. We've seen patients all the way from 2 days of life in our outpatient clinic up to age 66, and that is because we use Dr. Boxer's golden rule of pediatrics as anything that's younger than him. So Dr. Boxer, if you could raise your hand. That'll clarify our range for everyone who's here. That said, we actually have a wonderful relationship with our adult hematology colleagues who often will see patients in cooperation with us and come to the clinic. We also have a good cooperation with a lot of our other services in the hospital, including pathology. Dr. Ross, who's in the audience here, actually made a new diagnosis of a congenital sideroblastic anemia patient who was referred, and we now have a new hemoglobin, which we get to name out of our institution because of that. And while it's primarily an outpatient clinic, we actually quite often do inpatient consults when requested. We're often referred to as the Immuno-Hem SWAT team, which is kind of fun. We've been to many places that I didn't know existed in the hospital, and you can always tell when the pediatricians are there because we're really lost in UH. In terms of our areas of clinical focus, immunohematology is a little bit of a difficult term because it can mean a lot of things to a lot of people. For our group here, it means immunodeficiency syndromes, which is incredibly important because just a few months before we established the clinic, the state of Michigan actually began newborn screening with a TREC assay to look for severe T-cell deficiency or SCID, and those patients needed a home for rapid evaluation, and we do serve that function. We also host lymphoproliferative disorders. We have a huge family cohort of XLP. Neutrophil disorders, we have the largest population of neutropenia patients, thanks to Dr. Boxer's expertise, and bone marrow failure syndromes. And we have many patients who come to our clinic, and every once in a while we can get them to stop paying attention to their electronics for their exam or otherwise. In terms of our relatively narrow focus, you might think that we don't see very many diagnoses, when in fact we see an incredible array of diagnoses, and this is just a short list of the patients that we follow. The sizing reflects the number of patients, roughly, that are in our clinic as compared. Everything from complex rare diseases to some that are a little bit more common, like common variable immune deficiency. In terms of the providers, and these are our core providers, we have Dr. Larry Boxer, who is a pediatric hematologist, Jim Connolly, who is our bone marrow transplant physician, Dr. Mark Hannibal, who I mentioned is our immunogeneticist, Marsha McFawn is our family nurse practitioner who handles many of the day-to-day activities of our clinic, Dr. Terry Stillwell from Pediatric Infectious Disease, and myself, trained by Dr. Boxer in pediatric hematology. Most of our patients do come from within the Midwest or within Michigan, but when we made this map, even we were a little bit struck to see how far some of the patients have traveled for expertise that is particular here to Michigan, as far away as California or up in New York or Georgia. The other remarkable thing is that we've had families come most often to seek Dr. Boxer's opinion from other countries, and not just across the border in Canada, but from Costa Rica, Brazil, and Dr. Connolly will describe a very passionate family from Oman. And no matter where they come from, we're quite good at making them happy. If one sucker is good, then two is always better. Our clinical work also includes a patient care conference, which is a collaboration with the University of Pittsburgh, where we do a video conference once a month with formal presentations and long-term follow-up. We also have open conferences 2 weeks after that, so also once a month, where we have informal presentations and offer on-the-spot diagnostic and treatment recommendations. That conference can be really fun because we have a lot of guest invitees who have many interesting things to say, and this is improved for CME credit. Moving on to our second aim of research. We have some research infrastructure, which we're very excitedly building. We were the recipient of one of the Pediatric Discovery Grants, which is an intramural grant focused on multidisciplinary research. We've been developing our annotated clinical database and plan to have a coordinated biorepository within the next 12 months. Since July, when this award was provided, we've been actively enrolling patients into the 6 open protocols that we have, with 3 under additional IRB review and many more in the queue. And our goal, which is highlighted here at the symposium, is to really bridge the gap between clinical and bench science. So we're hoping we'll find some more friendly scientists out in the crowd who would like to join us. This is an example of a patient here with Dr. Connolly who actually, through our collaboration with the National Institute of Health, is getting further workup that we weren't able to offer here, trying to identify his exact immune deficiency, which unfortunately has eluded him and us for many years. The symposium is really a highlight of our interest in working with researchers. We're trying to focus on the merging of clinical care and research to try to find that magical translational middle ground. Our morning session will feature neutropenia and bone marrow failure and transplantation. You'll hear patient cases and how those inspired other research events. We'll take a break right from 12 to 1 for lunch and a poster session. We're very proud that we have 28 posters out for display, so please take a look at those. Many of our trainees have worked very hard to put those together. Our afternoon session will feature lymphoproliferative disorders, a brief story from a patient about the TREC assay experience here in Michigan for the primary immune deficiency segment, and then we'll be treated to a great best abstract presentation and, of course, the keynote speaker. I'm very excited and grateful that Steve Holland has made the trip from the National Institutes of Health to come deliver the keynote talk today, which, as you see in your schedule, is leukocytes, leukemia, and lymphatics. This has got to be good, and I will tell you I can guarantee it will. Our third aim for our program, as you remember, was really educational. We're happy to have an Immuno-Hematology Fellowship. Dr. Kristen Evans is seated here towards the front. She is currently our Vidara Immuno-Hem Fellow, thanks to a gracious, unrestricted gift that was provided to our program. That is a 12-month appointment awarded post a Peds Hem-Onc Fellowship, intended to foster academic development and commitment to the field of immunohematology, which Kristen has demonstrated excellently. You'll hear her talk a little later today, and she has a superb patient case as a poster as well. You know, our program tries to be really flexible to the need of our fellows because each one is individual and the diseases we study are quite unique. So we try to accommodate bench or clinical for our oriented candidates. And the clinical experience, and this is really the key part, is highly focused on immunoheme patients. We also have Holly Miller, who's here today, that will present briefly. And she is our Immuno-Hem Peds Hem-Onc Subtract Fellow. So this means after her first year of standard Hem-Onc fellowship, she can enter a 24-month appointment, which covers her second and third years. This sort of tailors her research to an area of immunohematology, and we also heavily slant her clinical experiences and educational exposures within our general program to an immunoheme focus. And this is Holly. Holly loves babies, so she tries to scoop up everyone that's in the clinic, and this is one that she managed to sneak in. We're also pleased to deliver an immunohematology education series, which we have asked several of you to participate in. It's a comprehensive series of 48 annual sessions. Anybody can join. These run Tuesday mornings from 7 to 8:30 a.m. And you can see the topics that are listed there, and that really makes up the bulk of our patient core. These were intentionally case-based and interactive in approach. There's pre- and post-testing. One of the most fun things we've done is actually a fellow debate. Many of the questions in our field are unanswered with a little bit of evidence on each side, so we put our fellows to the task to convince us one way or the other. It's also approved for CME credit, and we have a medical student rotation. It's an emergent curriculum, and you can see sort of our learning points for the students. We've had students both internally and externally. They're asked to do an academic project, whether that's a case report or a poster, many of which are featured today. And we always know how to show them a good time and all the important sites within our hospital. And importantly, I really want to take a moment to acknowledge all of those who have helped to contribute to our program. The Immune Deficiency Foundation was generous enough today to help facilitate Steve Holland's travel here. The Covans, who are seated in the front, have dedicated an enormous amount of time and funds to our program to help further rare disease study. The Charles Wisdom Pediatric Discovery Grant, which I mentioned earlier, and then Vidara Therapeutics, which has provided the unrestricted grants used for educational purposes. And of course, both our families and patients and our clinical and research collaborators. A big thank you to our planning committee, which Mark Hannibal chaired, and a huge thank you to Ashley Shaver, who most of you have seen running around or received numerous emails from. She is an amazing fourth-year medical student who has actually interrupted her fourth year to spend a year of training, research, symposium planning, et cetera, with our immunoheme program, and there is no way this day could have happened without all of her efforts. So please thank you for attending, and please be sure to give her a big high five as you walk around today, because she deserves about 5,000 of them. And then as you spend the rest of your day here, I hope that in some ways you're as curious or questioning as the child on the right there, and then at the end of the day, you're as smiling and happy as the trio of siblings there on the left.